I have no financial interest in this talk. So the incidence of postoperative endophthalmitis in cataract surgery may vary according to the series from 1.2 to 0.3, and the cefuroxime is the beta-lactam antibiotic with a strong activity against the gram-positive bacteria. They are commonly implicated in POE. It inhibits the bacterial cell wall synthesis, and many gram-negative are susceptible to intracameral cefuroxime, except the Pseudomonas. All we know the ESCRS study design, there are 4 groups. In 2 groups there are placebo drops or drops of antibiotics, but no intracameral cefuroxime. In the other 2 groups, the B and the D, they had intracameral cefuroxime plus or minus the drops of antibiotic. And the result was that without the intracameral cefuroxime, the incidence of endophthalmitis was among 0.3, so according to the literature, when with the intracameral cefuroxime, the incidence dropped down to 0.05. So the use of intracameral cefuroxime was approved in many of the scientific societies in ophthalmology all over the world, because we want to avoid the postoperative endophthalmitis. So we have to follow the mandatory preoperative steps like the antisepsis with povidone iodide. We have to consider risk factor, both surgical and patient-related, and we have to use the intracameral cefuroxime. But we have to remember that the intracameral cefuroxime is on label only for cataract surgery. In post-Plana vitrectomy, the incidence of postoperative endophthalmitis may vary from 1.5 to 0.02. The purpose of our study was to investigate the safety and the efficacy of 1 milligrams of aprocam, intracameral cefuroxime, at the end of combined phaco-vitrectomy. It was a retrospective analysis of 76 eyes of 76 patients. They underwent phaco, IOL, and small gauge post-Plana vitrectomy for various vitreoretinal societies, diseases associated with cataract, with various tamponates performed by various surgeons. These are the table for the pathologies, and 40 eyes were tamponated with air, 28 with SF6, 6 for siliconoid, both normal and heavy siliconoids, and 2 were left in balanced cell solution. We have to remember that the intracameral cefuroxime could have adverse events on the retina, especially if it was homemade, and the dose was more than the normal dose, than standard dose. We can have the macular infarction. But also, if the standard dose was used, we can have problem on the retina, like the appearance of the new intraretinal fluid or subretinal fluid. And the authors differentiated in these 2 works that there was no Irving gas syndrome because there was no leakage on the optic disc. And even if other kinds of antibiotics were used, even subconjunctival, we can have problems on the retina, like macular infarction with gentamicin subconj. The results of our study was that we find, luckily, no endophthalmitis, but the study was not powered to understand if the drug was effective in preventing endophthalmitis. We have no sign of anterior chamber inflammation, but most important, we have no retinal complication like macular or retinal hemorrhage or infarction, and no new subretinal or intraretinal fluid in any patient. In conclusion, it could be efficient in preventing endophthalmitis when using combined surgery. Despite the small number of patients, I told you it's not powered for decide this point. It was safe as no retinal adverse events occurred despite the intracameral use, and the various tamponades that were used, they can modify, especially the gas can modify, increasing the concentration of the cefuroxime, and despite the biostargen. Of course, it's an off-label procedure, and we need more clinical trials to approve this drug in combined surgery. Thank you.
I have a comment to the question of Barbara Parolini from the previous talk. There's a there's a guideline published from the German retinal societies and the other German ophthalmological societies in September 2013, and they clearly stated that there's no benefit of additional antibiotics, but you should take care about antisepsis and asepsis for intraocular injections.
But it's still a very hot topic also in Germany among the different surgeons, especially the cataract surgeons. And they say there is so much evidence by the study that we have to do that for prophylaxis. On the other hand, is if you have a very low number, which is below the low of the studies, so you asked what is the benefit of additional antibiotic prophylaxis in these eyes. So by now the German societies did not generally recommend cefuroxime antiprophylaxis so far. And your paper and also shown that a few eyes might, maybe that is concentration error or whatever this is, might cause retinal toxicity. So
yeah,
we have to question this.
It could have toxicity even with standard doses transient. Yeah. So the retinal fluid disappears spontaneously after 1 week to 10 days.
Also considerable cost implications using the Aprocam. I remember in England it's about $30,000 for 4,000 cases a year. So it's a significant cost as well.
From the floor. Question?
Yes. It has been said in the comments previously that iodopovidone kills almost every microorganism, but I think you mentioned it doesn't kill Pseudomonas. Pseudomonas can cultivate in iodine solution. So another comment about prevention is not to use big bottles of iodine povidone, but use single fraction for prevention. That was just a comment.
I think that's an excellent point. Most hospitals will use minims or small bottles, but some do not. So that's a very good point.